Welcome everyone to another Case a Minute video. Today we're going to be talking about anticoagulation. So this is the question that we're going to be going through. If you would like to pause the video now and try the question on your own before we talk through it, go for it. Otherwise, we're going to jump in. So the first sentence reads, a 58-year-old man with a history of mechanical mitral valve replacement and chronic atrial fibrillation presents for evaluation prior to an elective percutaneous liver biopsy. So first, the fact that this patient has a mechanical valve and also chronic AFib means that they need to be on anticoagulation chronically. With mechanical valves, you need to be on lifelong anticoagulation because of the risk of clots. And then similarly for chronic AFib, you need to be on anticoagulation because if you think about the atria of your heart just kind of like quivering in the atrial fibrillation, that stasis of the blood can allow a clot to form, and then that clot can, get pumped out of the heart somewhere bad, like the brain. So this patient is definitely on some sort of anticoagulation. We'll find out what. Um, and he is going to have a liver biopsy. So we are going to need to hold his anticoagulation for this procedure, hold and or potentially reverse, because if you're taking a little piece of the liver, you don't want to have a bunch of bleeding. And this is a pretty common situation where patients need to have a procedure, and so you need to stop, hold, and or reverse whatever anticoagulation they're on. Um, so a very common situation in the hospital. So he has been taking warfarin. Okay, so now we know he's on warfarin, and he has a stable INR of 2.8. So just to first talk about INR, what is INR? Basically, it's PT over a normalized PT. PT being the component that measures the extrinsic part of the clotting cascade, which we'll talk about. And the reason it's normalized is because different labs have kind of different ranges of values. So this allows INR to be on a scale that can be kind of compared across hospitals. And so for warfarin, you want the INR to be between 2 and 3. So this patient, his INR is stable, so it's good. He is at a therapeutic dose of warfarin. In a normal person who's not on warfarin, your INR would be around 1. So let's talk a little bit about anticoagulation. So of course we have to start with the clotting cascade. I pull a lot of pictures from first aid. I think first aid is not a great resource for IQ because it doesn't go into a lot of depth. But I will say I think this question or this picture is really great for Block 5. So as we can see at the top, talking about PT and APTT. So PT monitoring the extrinsic pathway and PTT monitoring the intrinsic pathway. So these are lab values that you can order. So I've heard people say PT playing tennis, you play tennis outside in the extrinsic, and playing table tennis, you play table tennis inside intrinsic pathway. And then, of course, looking at the clotting cascade, I'm not going to go through kind of all the great details, but um, extrinsic, you'd be thinking more like factor 7 over here. And then PT is kind of a lot of the rest of this. Everything's shown in this blue box right here. So what type of anticoagulation can we give? So a lot of them target 10A, which is right here in the middle, which kind of makes sense, right? If you're going to create a drug that blocks part of this pathway, you want to block something that's not kind of like high up in the cascade. You want something that is like a core component, and 10A is right here, kind of in the middle. So those include low molecular weight heparins, so things like enoxaparin, which you see very commonly in the hospital. Heparin is an IV medication. Enoxaparin is like an injection medication, and direct 10A inhibitors, so apixaban or Eliquis, another very, very common one that you see patients on because it's an oral medication. And then fondaparinux is another potential 10A option. And then Others inhibit thrombin, which is another factor right here, factor 2A. So heparin and low molecular weight heparin both inhibit thrombin. Direct thrombin inhibitors, obviously, hence the name, direct thrombin inhibitors, inhibit thrombin as well. So these are the, say, bivalirudin, dabigatran, agatroban. So these are some, but we haven't yet mentioned warfarin. So warfarin acts differently. It inhibits vitamin K epoxide reductase, which is an enzyme that converts vitamin K from its inactive to active form. And then that's important because vitamin K then acts to activate a bunch of coagulation cascade clotting factors. So in particular, 2, 7, 9, and 10, which I would memorize those numbers because they will always come up. So as you can imagine, 2, 7, 9, and 10 are like some of the main, that's like a lot of the factors that we're hitting. So warfarin is acting to inhibit a whole bunch of places of the clotting cascade. And you're monitoring INR, which is kind of a measure of the extrinsic pathway because we're over here with impacting factor 7. So some facts about warfarin, some fun warfarin facts. It is an older drug, so it's been around for a long time, which means a lot of studies have been done using warfarin. So for some diseases, that's a reason why warfarin is given. It's also cheap because it's an old drug. So some patients, even though Eliquis might be a good option for them, their insurance may not cover it. It's expensive, so they end up going on warfarin. Um, I didn't put it here, but another big thing with warfarin is you will need to bridge onto warfarin. So it has a long half-life, long onset, long offset. The half-life for stat pearls is about 20 to 60 hours, so on the order of days. It takes a long time to kind of get the INR up as well, while on warfarin. So you have to bridge with heparin, also to um, prevent warfarin skin necrosis, which can happen because warfarin also acts at these, go back, um, protein C and protein S, which are anticoagulants. So you can have thrombosis early on. So you have to bridge with warfarin, or sorry, with heparin. It also has a narrow therapeutic index. So that means that it can interact with a lot of other drugs. Also, if people change their diet, change the amount of, say, vitamin K that they're eating, that's going to change the way warfarin is working. So that's why it's important to measure INR. And it's kind of a burden on patients because they'll have to come into the Coumadin clinic, Coumadin being the brand name for warfarin, to have their INR measured. If it's too low, then they'll have to up the dose. If it's too high, they'll have to decrease the dose. And patients will have to come in somewhat frequently to have their warfarin redosed until it's at kind of a stable place. Okay, so now let's get to the meat of the question. The interventional radiology team plans to temporarily interrupt anticoagulation, so they're going to stop the medication. Which of the following agents is most appropriate for rapid reversal of warfarin? So, like we said, we need to have this patient not be anticoagulated so that they can get this procedure and not bleed. But warfarin has a long half-life, so we can't just stop it. We need to actually reverse it if we want to do this more quickly. So let's look at our answer choices. Protamine sulfate, adenexate alpha, idrisizumab, four-factor prothrombin complex concentrate, and vitamin K. So of these, I would say D and E sound pretty good. Just to remind you, PCC option D, this is something that contains factors 2, 7, 9, 10, protein C, protein S, which sounds a lot like the factors that warfarin impacts. And then just as a side note, FFP, I often confuse with PCC, those three-letter acronyms that get you. FFP, fresh frozen plasma, has all the coagulation coagulation factors. So PCC would be a good option because you're replacing the factors that get kind of inhibited by warfarin. And then vitamin K seems like it also might be a good option, right? Because if warfarin works by inhibiting the conversion of vitamin K, you could just give more vitamin K to kind of overcome that and then have the factors be replenished. So probably D or E, but let's look at these other answers. So protamine sulfate is used to reverse heparin. Adenexate alpha is used for reversing direct factor 10A inhibitors, and idrisizumab is used to reverse dabigatran. So probably none of those three. And then if we're thinking between D and E, which one would be more rapid, right? Because that's what the question is asking. Well, if you give vitamin K, then the patient's body is going to have to use that vitamin K to produce more factors. That kind of takes a long time, probably, versus just giving the factors themselves. And in fact, when I looked this up, giving vitamin K takes about 24 hours to replenish the factors, give or take. So I would say D is probably the best answer. And just to pull up this anticoagulation reversal snippet from first aid, we see heparin is reversed by protamine sulfates. It's a positively charged peptide that binds the negatively charged heparin to inactivate it. We talked about vitamin K with or without FFP and PCP, and sorry, PCC for warfarin. We talked about for dabigatran, this monoclonal antibody that is used to reverse it. And then adenexate alpha for direct factor 10A, which is just a recombinant factor 10A. So indeed, D is the answer here. So I think this is a good question. You could just read through and based on your knowledge of that table that I just showed you, probably pick the correct answer. But it's really important to understand the coagulation cascade um, in that, the way that these drugs work with regards to the cascade because this comes up a lot, right? Tons of patients are on these medications. I swear, like every patient that walks in the door is on warfarin or on Eliquis, or you're going to start them on heparin, or you're going to start them on Lovenox to prevent DVTs. And it's really important to know how these medications work.